Good morning, everyone. My name is Jon Bar, aka MD4 with Cooper Medical Command, and welcome back to this edition of Bringing Out the Ad. This time we're going to tackle a topic that gets relatively little attention, I think, in EMS education, and that's the topic of the Brue, or sometimes people might pronounce the E and call it a Brue. So first we're going to talk about what actually is a Brue, what are the characteristics of it, what's important in the field, and then what's the best disposition. So first of all, what is it? So Brue stands for Brief, Resolved, Unexplained Event. Again, that's Brief, Resolved, Unexplained Event. And we're going to break that down a little bit further. Now, you may have also heard these terms, the term Alti, which was an older term that stood for Apparent Life-Threatening Event. That term has since fallen into disuse with the American Academy of Pediatrics. I've also seen some EMS providers write down in their charts something like the patient had no Alti to mean no acute life-threatening events. Use of this terminology can be confusing, and so I would recommend if you're in a situation where you have a child who may have had some type of event where they were lethargic or maybe went apneic or something like that, the best thing to do is to describe exactly what you saw and avoid these acronyms to avoid any possible confusion. So if you need help remembering, remember Fry wants to enjoy that tasty Brue, and we're not really using Alti anymore. So what are the characteristics of a Brue? So it's a sudden, brief, and brief means like less than 1 minute, often only 20 or 30 second event that is now resolved, and that's really important. So it was short and it's now resolved. By definition, it's resolved now and it's gone away. And this event can look like cyanosis or pallor, so change in color. It can be a change in breathing, such as a brief period of apnea, change in breathing pattern, or change in breathing rate, usually decreased. It can be a change in tone, so the child can appear floppy, or change in responsiveness, level of responsiveness. And importantly, a Brue is also unexplained. And that's the really important thing. That's what's going to make it hard for you to cinch this diagnosis in the pre-hospital setting, because patients who have one of these events need to undergo evaluation for other possible causes. So it's important for you to know that, because these patients generally need to go to the ER to have evaluation for those other causes. So in what patient population should you even consider Brues? And it's in your infants, particularly the infants less than 1 year of age. So again, infants less than 1 year of age are the population where you might have to be concerned about a Brue. Remember, Brue is a diagnosis of exclusion. Don't be tricked because the patient appears well now that this was just an over-anxious parent or be dismissive of what they say. Trust what they say, get their description of the events, and remember, this is a diagnosis of exclusion, and you need to get them to the hospital, and that's why it's important to consider, because you need to get them over to the hospital to have evaluation for other possible causes. So children who have one of these short events like this may potentially have another serious life-threatening condition, and as you can see, the list of possibilities is long, such as serious bacterial infections, seizures, non-accidental trauma, poisonings, respiratory diseases like pertussis and bronchiolitis, cardiac disease, hypoglycemia, and others. So it's important to recognize that Brue is a diagnosis of exclusion, and therefore these patients should ideally be transported to have evaluation to exclude these other possible life-threatening causes of the event. Now, what's important for you to do as an EMS provider when you get in the field? One, you're going to do what you always do and take a good history. In particular, for an event that sounds like a Brue, you want to try to get the exact circumstances. Again, remember, just write down exactly what you saw and exactly what you were told. It's important to note if the patient had CPR at any point, if a bystander had tried that, how long the event lasted, is this the first time? And that's really important because recurrent events raise the risk level. Take a look at the social circumstances. Remember, I said non-accidental trauma is something that needs to be excluded in these cases, and so check the environment, see what the social circumstances are like, see if there's any concern for that non-accidental trauma. It's also a good idea to get a birth history to know if the patient was born premature and how many weeks they were at birth. Then you're going to do your physical exam, and it's important on these patients to get a full set of vitals. That's really important to do in this case. If you have a pulse ox, you can apply it, but we'll remember the limitations of pulse ox, we'll talk a little bit more about that in a second. And in particular, pay attention to the color of the skin, pay attention to the patient's mental status, and as well as look for any signs of trauma, which may be subtle. And we'll be covering that in more detail in a later talk. So, what are you going to do? You've done your history, you've done your physical. If the patient appears to be in respiratory distress or their SAT is low, then you should apply some oxygen. So remember though that your pulse ox in children can be inaccurate if the patient's moving around, if they're cold, if in settings of carbon monoxide, methylglobulinemia, or something simple as if there's nail polish or something else there. So don't be totally reliant on the pulse ox, can help you, but you do really want to look at the patient and look, see if you see that skin pulling on the neck and the chest. Look for that belly breathing, look for that cyanosis or blue nail beds, look for pallor in the skin, look for the flaring of the nostrils. Sometimes these children can look frightened. So this stuff, how the patient actually looks to you, is what's going to be the most important. So I'm going to star it because that's really what you want to pay attention to the most. Now you might be wondering, do I have to call ALS on these patients? So remember that oftentimes the event itself has now resolved and the infant appears well. So if the infant appears well and is not otherwise in distress, ALS is not routinely required. However, if the patient now appears to be in respiratory distress or has another reason why they would meet ALS criteria, then you should request ALS. In general, do not delay transport to allow for arrival of an ALS unit. If the patient were to deteriorate en route, it's okay to bag the patient and use BLS, airway, and oxygenation techniques. And I would not wait for ALS. The important thing is to get these patients over to the hospital. Now, which hospital should you go to? So specifically, you should go to a pediatric center. Again, a pediatric center if the patient's under 2 months old, has a history of prematurity, or this has happened before and they've had more than one Brue in the past, then that raises the risk level and you should go to a center that has pediatric expertise. So let's summarize it up. A Brue stands for brief, resolved, unexplained event. It occurs in infants less than 1 year of age. Again, less than 1 year of age. Importantly, because these events are by definition now resolved, the child might look well, but remember that some of these patients will have another life-threatening condition that needs to be excluded, and so don't be dismissive and still encourage these patients to go to the hospital and have them be transported. Treat the symptoms that you see in front of you. So if they appear to be in respiratory distress, apply oxygen or utilize your normal respiratory support techniques. And for those infants who are less than 2 months, are premature, or who have had multiple events like this, transport to a center with pediatric expertise is the best thing to do for the patient. Thank you guys for listening in. Stay safe out there. MD